Hello, my name is Guillaume Favre. I am an obstetrician currently working in the obstetric unit at Lausanne University Hospital in Switzerland. I will present last updates on COVID-19 vaccine among pregnant women. But first, a brief update on the overall COVID-19 situation. Here, we have a graphic representing global SARS-CoV-2 confirmed cases. We are deep in this pandemic, with more than 100 million of people tested positive for the virus, and more than 2.5 million deaths due to the COVID-19, and it's still increasing. One of the strategies to fight the pandemic is massive vaccination. Currently, several vaccines have been developed in emergency and used in many countries, as you can see on the figure. But most of countries have vaccinated a small number of their population due to many limitations. To organize this public health strategy, most of countries have planned to prioritize vaccination to high-risk groups, including, depending on local guidelines, elderly people, people with chronic disease, or healthcare workers. However, as you can see on the map, it's also important to highlight that not all countries have access to vaccination. And what about pregnant women? It is now known that they are at increased risk of severe form of COVID-19, with increased risk of ICU admission, mechanical ventilation, or maternal death. Several studies have spotted significant risk factors of severe form of the disease: chronic hypertension, pre-existing diabetes, chronic pulmonary disease, and obesity with a BMI more than 30 are at risk of severe COVID-19. They have also increased risk of preterm birth and increased risk of cesarean section, but a part of it was associated with a high rate of iatrogenic intervention at the beginning of the pandemic. We know now that cesarean section does not prevent any adverse outcome among pregnant women with COVID-19. There is still questions about the involvement of SARS-CoV-2 in the possible higher rate of stillbirth. Regarding the neonates, the transmission from the mother seems to be rare, and exceptional critical adverse outcomes are reported in the literature. Note that at the beginning, most of the people considered pregnant women at the same risk of severe form of COVID-19, whereas pregnant women were compared to general population. But the pregnant patient is not age of 60 years old, and she is at higher risk of severe form of the disease than a non-pregnant woman of the same age. On that comparison between general population, including elderly and pregnant women, we have quite similar rates of severe and critical cases. But here we can see that the age range is totally different, and it has been shown by the John Allore meta-analysis. Now let's look back to vaccination in pregnancy. Several vaccines are recommended during pregnancy. They are considered safe and beneficial for pregnant women. We have the pertussis vaccination associated with tetanus and diphtheria. Pertussis vaccine injection is recommended for each pregnancy, preferably at the end of the pregnancy, from 27 to 36 weeks of gestation, to confer pertussis immunity to the mother. Maternal antibodies will then pass through the placenta, likely providing the newborn with protection against pertussis in early life. This will protect the mother from pertussis around the time of delivery, making her less likely to become infected and transmit pertussis to her infant. And it is proven that it is twice as effective to get vaccinated at the end of the pregnancy than to be in the immediate postpartum. And there is no increased risk of being vaccinated during pregnancy, even when there is closely spaced pregnancies and iterative doses. Regarding influenza, pregnant women are particularly vulnerable to that infection. The efficacy of seasonal influenza vaccination in pregnant women is similar to its efficacy among the general adult population, and no increased adverse events was reported. On the other hand, live-attenuated vaccines are contraindicated in pregnancy based on the theory that the woman could possibly be infected by the pathogen, but no increased risk were demonstrated concerning live-attenuated polio, yellow fever, and rubella vaccines. Given that these vaccines can be delayed after pregnancy, they are not recommended for pregnant women. These vaccines were developed a long time ago, and we had years to study them even among pregnant women. But what's going on with the new vaccine technology and rapidly developed vaccines in pregnant women? What's going on when we do not have all these years of hindsight? I would like to illustrate these questions of major concern with a story. Maybe some of you know this little girl. Her name is Nubia. She was born in Guinea during Ebola outbreaks. and the woman who is holding her is not her mother. To understand Nubia's story, we need to have a glimpse to the Ebola crisis. Ebola is a virus causing a hemorrhagic fever, responsible of 80 to 90% death rate when infected without treatment, and a fatal death rate of 100%. Back to 2016, after fighting for pregnant women and strong negotiation, Severin Calwatz, an obstetrician working with MSF, reported that they obtained exceptional authorization to use favipiravir in pregnancy as an experimental treatment for Ebola. After being diagnosed for Ebola disease, Nubia's mother received that experimental treatment. Nubia's was born 4 days later, and her mother passed away 7 hours after delivery of a postpartum hemorrhage, despite appropriate management of the situation, but complicated with disseminated intravascular coagulation consecutive to Ebola. Nubia's mother was previously denied access to potentially protective vaccination due to pregnancy. Even with this story, the fatal consequences of the virus, pregnant women were still systematically excluded from new clinical trials reported in 2018. And what about Zika? Zika virus is known to cause a 26% maternal fetal infection in pregnant women, with 14% of fetal death and 21% of congenital Zika syndrome. Several vaccines have been developed with DNA, RNA, and inactivated virus technology, theoretically harmless for pregnant women. Vaccines have been through phase 1 and 2 clinical studies and remain safe in animal models, but still, pregnant women excluded. Or pregnant women will be allowed to access future clinical trials? We'll need to wait until next outbreaks. And here again, with COVID-19 vaccine. Pregnant women are not part of the clinical trials project. According to the WHO statement of June 2020, pregnant women do not appear to constitute a high priority group despite the increased risk of severe complications. In this publication, the research team led by David Beau implored the WHO and International Obstetric Society to consider pregnant women for COVID-19 vaccination trials. An updated article published in December 2020 reported that pregnant women were excluded from phase 3 clinical trials regarding COVID-19 vaccination. The author well states that withholding vaccine violates ethical principle of autonomy as well as beneficence and justice. Of course, they remind that there is a theoretical risk of fatal harm from any untested medical intervention. Given that current situation, they conclude that pregnant individuals should be given the opportunity to weigh the potential risk of severe maternal disease against the unknown risk of fetal exposure and make an autonomous decision about whether or not to accept the vaccine. 12 vaccines are currently used by at least one country, and many others are still in development. None of the vaccines trials have included pregnant women despite their theoretical harmless technology. So how do these vaccines work? mRNA, protein subunit, non-replicating viral vector technology contains no viral pathogens. It only contains instruction for producing antigens, an antigen itself that stimulates the immune system. Note that all animal models on COVID-19 vaccines reported no adverse event during pregnancy. The mRNA vaccine is composed of a specific messenger RNA wrapped in a coating coding for the spike protein of the virus. It is injected to the patient and it will enter into the cell cytoplasm, delivering the mRNA without going to the nucleus. This mRNA will be translated to spike protein and transport at the surface of the cell, activating our immune system. And it does not contain the coronavirus. The non-replicating viral vector vaccines are composed of a modified known virus, as the adenovirus used in the AstraZeneca, Sputnik V or Covishield vaccine. The virus is modified that it cannot replicate itself and contains a DNA sequence coding for the spike protein of the coronavirus. It enters the nucleus, transcripted into mRNA, then goes to the cytoplasm, translated into the protein, and transported at the surface of the cell. and it does not contain the coronavirus as well. The subunit vaccine is composed of the spike protein that is directly injected to the patient. Because the spike protein is not exposed at the surface of the cell, the vaccine contains a substance called adjuvant to increase the immune response. Again, no virus is injected. As of March 2021, several international societies at the Society for Maternal and Fetal Medicine, the WHO, and national obstetrical societies recommend vaccination for pregnant women at high risk of severe COVID-19 and highly exposed pregnant women. But, according to this publication, despite national and international recommendations from scientific societies, several governments do not include pregnant women in their vaccination plans. Accidental vaccination in pregnancy were reported as part of clinical trials. They had similar rates of pregnancy, which mean the vaccine does not appear to influence sterility. And similar rates of miscarriages, or even slightly lower in the vaccinated group, were observed. In practice, Dr. Anthony Fauci, director of the National Institute of Allergy and Infectious Disease in the USA, stated on February 10th that approximately 20,000 pregnant women have been vaccinated with no red flags, and this was monitored by the CDC and the FDA. 1 week after Dr. Fauci's statement, Pfizer-BioNTech announced a global phase 2-3 trial of their COVID-19 vaccine in 4,000 healthy pregnant women. The placebo-controlled, observer-blinded study will track the safety, tolerability, and immunogenicity of 2 doses of vaccine 21 days apart, compared to placebo for 7 to 10 months. The trial will also assess safety in infants of vaccinated mothers and the transfer of antibodies from mother to child for up to 6 months after birth. A recent article was published as preprint, reporting the first infant born from a mother who was vaccinated at 36 weeks of gestation because she was a frontline healthcare worker. She gave birth 3 weeks later of a healthy little girl with detectable antibodies in the cord blood, raising the question of potential protection in the newborn. In that emergency context, observational studies are needed, and especially in this challenging group of pregnant patients regarding a new vaccine. That is the reason we upgraded our COVID-PREG registry, allowing collaborators to identify and collect not only pregnant women suspected of SARS-CoV-2 exposure, but also those exposed to the vaccine. After registering on covidpreg.ch, you will have access to the COVID-PREG platform, an online turnkey solution to collect data on these patients. By participating to COVID-PREG, you are not only a member, but you are part of every publication aiming to assess the safety and efficacy of the vaccine among pregnant women. So, what to keep in mind about COVID-19 vaccine and pregnancy? First, COVID-19 vaccine is recommended by scientific societies during pregnancy for high-risk exposure and high-risk comorbidities patients. Even if we have very reassuring information about vaccination in pregnant women, we lack of strong data and studies are urgently needed. At least one clinical trial is ongoing in pregnant women, but observational studies are necessary to assess the already vaccinated population. And eventually, we need to fight for pregnant women to have them included in clinical trial protocols for the future. If you have any question about COVID-PREG, you can contact me by email or directly register on covidpreg.ch. Thank you very much for your attention.